Acute pancreatitis. This is one of the most dreaded diseases to afflict mankind in view of its high morbidity and mortality. There is a rising incidence of acute pancreatitis, essentially because of an increasing incidence of gallstones and obesity. Pancreatitis occurs due to a chain of events which are triggered by a temporary or permanent obstruction to the pancreatic duct. This results in a release of pancreatic enzymes into pancreatic interstitium and peripancreatic tissues, resulting in an inflammatory response and, more importantly, autodigestion of tissues. Acute pancreatitis is actually characterized by two phases: an early phase, which is during the first week, and this is dominated by the systemic inflammatory response syndrome. In the systemic inflammatory response, there is a release of inflammatory mediators, essentially cytokines, which activate and intensify an inflammatory cascade, which may finally culminate in organ dysfunction and multi-organ failure. There's a second phase, which is the later phase, which occurs after the first week and is dominated by local complications due to pancreatic and peripancreatic necrosis. A very important point to note is the first week of acute pancreatitis, when essentially the predominant feature is the systemic inflammatory response syndrome. In this phase, there may be minimal changes seen on CT, but the patient is clinically very ill and there are severe systemic effects. This mismatch which occurs between the extent of local pathology seen on imaging and systemic features occurs because during this first week there is a release of cytokines resulting in the systemic inflammatory response syndrome. And the magnitude of the systemic release of inflammatory mediators is responsible for the morbidity and mortality in early pancreatitis. And this is the reason why CT is not useful in the first week of acute pancreatitis, because the changes seen locally are minimal and main features are the systemic inflammatory response syndrome. Unless, of course, there are severe complications or the diagnosis is in doubt, then CT is useful in the first week. The mortality which occurs in acute pancreatitis is essentially because of multi-organ failure, and this follows this biphasic pattern: early due to the systemic inflammatory response syndrome and later due to local sepsis. The diagnosis of pancreatitis requires two of three features. The first feature is abdominal pain, which typically is epigastric and radiates to the back. The second is a serum amylase lipase level, which is elevated and should be at least 3 times upper limit. Just a slight elevation above the upper limit is not enough to make the diagnosis. It must be 3 times the upper limit. And the third feature is the characteristic findings of acute pancreatitis on CT. If 2 of these findings are present, that is abdominal pain and elevated amylase lipase, then CT is not required for the diagnosis, which is now why we see that CT is not done immediately to make the diagnosis, as in the first week it's of not much value. So if we have the 2 clinical features, then CT is deferred till after the first week. Still, and especially after the first week, the single and most important factor in reducing morbidity and mortality today has been the CT scan. And that's why it's so important for us to understand the role of CT scan in acute pancreatitis. When we look at acute pancreatitis, it's good to divide it up into 2 types because they have total different outcomes. The first is interstitial edematous pancreatitis, and the second is necrotizing pancreatitis. In interstitial edematous pancreatitis, this is a mild process which is self-limiting with transient edema, so it has a very, very good outcome. What we see on imaging is a mild swelling of the pancreas with loss of its normal lobulations, a diffuse decrease and attenuation of the pancreas, and in 1/3 of cases, actually, the CT may be normal. Here's a CT of a patient with acute interstitial edematous pancreatitis, and what we see here is a homogeneous enlargement of the pancreatic gland. The attenuation of the pancreatic gland is also homogeneous and enhances homogeneously. Similarly, here are other examples showing the same features where there is a homogeneous enlargement of the pancreatic gland, homogeneous attenuation of the pancreatic gland. Again here, homogeneous enlargement with homogeneous attenuation. No areas of hypodensity within to suggest pancreatic necrosis. MRCP An MRI of the abdomen is very useful for looking at CBD calculi, which can be a precursor to acute pancreatitis. So often we have MRCP or MRI of the abdomen done looking at the CBD, and of course at the same time they would like us to look at the pancreas. So it's important to be aware of the findings of MRI in acute pancreatitis. Here's an example of a patient with acute edematous pancreatitis, where you see on the routine T2 weighted images an enlargement of the pancreatic gland. But very, very important is on the STIR images, which is so sensitive to fluid, you actually see the interstitial edematous changes occurring in the pancreas, as there is a hyperintensity seen within the head, neck, and the body of the pancreas. And post-contrast resembles CT, where you would see a homogeneously enlarged gland with homogeneous signal intensity and no areas of hyperintensity to suggest necrosis. Necrotizing pancreatitis, on the other hand, is a fulminant form of pancreatitis which is characterized by the presence of necrosis. Necrosis essentially represents areas of non-viable pancreatic and peripancreatic tissue. And dynamic CT is the most accurate modality to detect necrosis. When I mean dynamic CT, it means basically contrast enhanced CT. Pancreatic necrosis, the size, extent, and location of necrosis is very variable. CT, however, accurately correlates with the surgical findings, and the greater the necrosis, the worse is the prognosis. So necrosis is very, very important, helps us determine how much of the gland is necrosed, and obviously what would be the prognosis. Further, necrosis may get resorbed, may get walled off, or may get infected. And these are examples of acute necrotizing pancreatitis, where what we see are, of course, an enlarged pancreatic gland, but within the pancreatic gland there is inhomogeneous attenuation, large areas of hypodensity within the pancreatic gland. Again here, an enlarged pancreatic gland with multiple hypodense areas within, representing areas of necrosis. And here again you can see that the pancreatic gland is considerably enlarged, and there's an ill-defined area of hypodensity within the neck and the body of the pancreas, with multiple smaller areas of hypodensity within the body of the pancreas, all representing areas of pancreatic necrosis. Here's another example where you can see that, of course, the gland is enlarged, but there's this large area of hypodensity occupying nearly the entire neck, body, and tail of the pancreas, which is necrosed, and this is non-viable pancreatic tissue. And adjacent, there is peripancreatic necrosis, which we'll talk about subsequently. As I said, important to know MR features in acute pancreatitis, and here's an example of patient with acute necrotizing pancreatitis on MRI, where you can see on the T2 weighted images that the areas of necrosis are hyperintense, basically now basically turning into fluid content acute necrotizing pancreatitis, and fluid collection along the surface of the pancreas and areas of non-viable pancreas. And that's further confirmed with a contrast study where you can see that this doesn't enhance at all. Small areas of pancreatic tissue here which are viable demonstrate enhancement. In addition to the changes that we see within the pancreas, there are significant changes that we see in the peripancreatic tissues. And this is termed as peripancreatic inflammation. It's a whole gamut of conditions which include acute pancreatic fluid collections, acute necrotic collections, and subsequently, after 4 weeks, these collections transit. Acute pancreatic fluid collections become pseudocysts, or they get resorbed. Acute necrotic collections may get resorbed or form walled-off necrosis, or these collections can get infected, which is the main complication of acute pancreatitis, resulting in pancreatic and peripancreatic sepsis. Acute pancreatic fluid collections are enzyme-rich pancreatic fluid collections. 40% of pancreatitis have fluid collections, and these essentially occur due to a rupture of peripheral ductules, resulting in exudation of pancreatic enzymes into the pancreatic interstitium with associated fluid collections, which subsequently leak into surrounding tissue spaces. These get localized by the anatomical plane that they collect in, as well as they disrupt and dissect tissue planes. On imaging, we see homogeneous fluid collections, important is that there should be no internal contents and especially no fat necrosis. Because as soon as there are internal contents and fat necrosis, we need to term these now under the new Atlanta classification into acute necrotizing pancreatitis with necrotizing fluid collections, acute necrotic collections. Here are examples of patients with acute pancreatic fluid collections, where you can see homogeneously enlarged pancreas here with evidence of peripancreatic fluid collections along its anterior surface. Here again, well-defined peripancreatic fluid collections, and here peripancreatic fluid collections which are tracking in the left paracolic gutter along the thickened Gerota's fascia out here, but homogeneous fluid collections with no debris within. Acute pancreatic fluid collections, 50% of them spontaneously resolve, 50% of them evolve into pseudocysts. And pseudocysts are essentially termed as an acute pancreatic fluid collection which has an enhancing capsule after 4 weeks with no necrotic debris, as I mentioned before. These may get complicated with infection, hemorrhage, or rupture, but these complications are relatively rare. Examples of pseudocysts, as you can see, very well defined, homogeneous fluid collection with no evidence of any necrotic debris within. In this patient, you have multiple walled off homogeneous fluid collections with enhancing capsules representing pseudocysts, multiple pseudocysts. Again, another example of multiple pseudocysts, large, well-defined fluid collections. And all these fluid collections are homogeneous with fluid attenuation and within their contents. MRI, again, important to look at, to be aware, and MRI is actually very, very useful now in sometimes differentiating acute pancreatic fluid collections from acute necrotic collections, because it's able to demonstrate the internal contents within the fluid collections quite well. So here you see a very well-defined homogeneous fluid collection representing a pseudocyst, similarly seen here. There is no debris or any altered signal intensity seen within these collections. As I said, occasionally you may have complications in a pseudocyst, which may be infection or bleeding or within the pseudocyst. And here's an example of a large pseudocyst which had an internal hemorrhage, and you see altered signal intensity within because of areas of hemorrhage. Acute necrotic collections are very important because these are part and parcel of acute necrotizing pancreatitis, and these are the collections that we have to watch because they may get infected and be the source of pancreatic sepsis, which contributes significantly to the morbidity and mortality in acute pancreatitis. Acute necrotic collections could be a combination of pancreatic or peripancreatic necrosis with pancreatic and peripancreatic fluid collections. These tend to be of varying consistencies. They may be liquid, they may be solid, or they may be a combination of liquid and solid. They tend to be ill-defined or partially walled off. When purely liquid, it is difficult on CT to differentiate acute pancreatic fluid collections from acute necrotic collections. The only way we are able to really differentiate is by demonstrating whether there is evidence of necrotic debris or fat necrosis within the fluid collections. And that's why sometimes it's difficult on CT and becomes easier with sonography or MRI. Previously, sonography had really no role in acute pancreatitis, but this is an area where it is starting to show a role by being able to demonstrate debris and not a homogeneous fluid collection. Typical appearance of peripancreatic necrosis, where we see dirty fat or ill-defined soft tissues, ill-defined areas of liquid or fluid collection seen within the peripancreatic tissues. Here mainly what we see is solid tissue which is hypodense, some amount of enhancement, but multiple areas of fat necrosis and fat densities seen interspersed in this, which is essentially suggestive of an acute necrotic collection or peripancreatic necrosis. Multiple CTs which demonstrate varying extent of solid and liquid peripancreatic necrosis. Here it's basically solid, where you see multiple focal hypodense areas within the fat, altered fat with representing peripancreatic necrosis, fat necrosis. in this case, there's a combination where you have solid components as well as liquefied components and more solid components. So at varying consistencies out here, but the features are very similar. Again, in this case, a combination of focal areas of necrosis in addition to obvious enlarged pancreas, but multiple areas of altered attenuation in the adjacent fat. And here's one where you see a fairly large fluid collection out here, and you see multiple areas of necrosis interspersed, solid necrosis interspersed in the adjacent fat. Here is an example where initially this used to be called as an acute pancreatic fluid collection, because essentially what we saw was a large fluid collection seen in the peripancreatic tissues. But very important to note is that there's fat densities within this, and as soon as we have fat densities, it has to be called an acute necrotic collection. The reason being because these don't drain well with pigtail catheters, and the management is different. We would want to drain these acute necrotic collections, which look fairly liquid, by thick bore catheters, which are basically the ICD catheters that we use, and we'll talk about that a little later. Again, MR, important to know the features. Here's an example of a enlarged pancreas, but adjacent to it you can see there's alteration of the fat, and that's quite nicely seen here. You see multiple densities and small areas of altered signal intensity in the adjacent peripancreatic fat, and these all represent areas of peripancreatic necrosis. After 4 weeks, peripancreatic necrosis may get resorbed, may get walled off, or may get infected. So walled off necrosis is an important new term which has been introduced. As necrosis matures and evolves, an interface develops between the necrotic tissue and adjacent fatty tissue. So it gets a thick enhancing wall. This may be solid or liquid, but there is always necrotic debris within. And as I've mentioned earlier, important to differentiate from a pseudocyst, and this differentiation is based on the presence of necrotic debris. Pseudocysts can be drained, walled off necrosis can be drained with large bore catheters or surgically removed. Here's an example of a fluid collection seen in the lesser sac, and this earlier would have probably been termed as a pseudocyst, but what we see here is that we see fat densities and necrotic contents within the collection, and therefore would be termed an acute necrotic collection. Here are examples of walled off necrosis, where you can see well-defined fluid collection seen in the lesser sac with a thickened enhancing wall and evidence of fat density within. Again, examples of walled off necrosis, multiple examples of walled off necrosis where you can see a thick wall and a walling off of the necrosis, and then the fat densities within, which will term it as an acute necrotic collection. Here's again an example where you can see it's walled off and focal areas of fat density seen within the collection. Again, multiple examples where it looks to be quite a liquid fluid collection out here, but you can see the fat densities within. So examples of walled off necrosis, but with necrotic components. On MRI, we would see acute necrotic collections like fluid collections, but evidence of debris within. And the presence of this debris within helps us differentiate, sometimes which is difficult on CT. Again, examples to demonstrate fluid collections which are acute necrotic collections because they have the presence of debris within them, and they're not homogeneous like what we would see with a pseudocyst. An important point is that any collection seen even within the pancreatic gland is termed as an acute necrotic collection. An MRI to show an acute necrotic collection within the pancreatic gland, which looks like relatively like a well-defined fluid collection on the post-contrast MRI, but any fluid collection within the pancreatic gland, according to the New Atlanta classification, would represent acute necrotic collection, and we can see that out here quite well. And an important point was that this collection actually showed diffusion restriction and ADC drop, and went on to be proven actually as a focal area of pancreatic sepsis. Just to show you a few examples of the progress that happens with walled-off necrosis, here is a collection with actually specks of air suspected to be pancreatic sepsis. Patient was treated with antibiotics, and on the subsequent scan, you could see that the collection regressed considerably. Here's again an example with multiple areas of necrosis, acute necrotic collection in the peripancreatic tissues, and subsequently on the follow-up scan, you can see that this is cleared up. So walled-off necrosis over a period of time can get resolved. Patient with initially who had an MRI done, which demonstrated acute edematous pancreatitis with peripancreatic fluid collections, and you can see the fluid collections quite nicely on the CT study. So this looked initially like an acute edematous pancreatitis, some areas possibly of necrosis in the pancreas, but with just peripancreatic fluid collections. A patient went on to develop acute necrotic collections on the subsequent scan, which got walled off. So you see fairly nice walled off collections that are occurring, very well defined, walled off, but you can see it's relatively solid consistency of the collection, and the patient was then subsequently treated with actually a stent being placed between the stomach and the necrotic collection, which drained into the stomach. And this is subsequently, you can see that the pancreas is returned to relatively normal size, but all the walled-off necrosis around has totally resolved. So they're fairly new, innovative techniques of handling walled-off necrosis rather than just surgery. An MR example of a patient with walled-off necrosis, where you see a well-defined fluid collection here with evidence of debris within it, signal intensities within the collection out here, and then a follow-up scan where no surgery, just patient followed up, following antibiotics, and you can see that the walled-off necrosis has actually resolved and resolved. So when we look at peripancreatic inflammation, important to see the new Atlanta classification, which is quite specific now. Fluid collections which are in the first 4 weeks with no necrosis or infection are termed as acute pancreatic fluid collections. After 4 weeks, when they encapsulated, acute pancreatic fluid collections without necrosis are termed as pseudocysts. Fluid collections after the first 4 weeks, fluid collections in the first 4 weeks with necrosis are termed as acute necrotic collections. Encapsulated fluid collections after 4 weeks with necrosis, walled-off necrosis. Any intraparenchymal fluid collection due to pancreatitis, as I mentioned and showed that case earlier, are referred to as acute necrotic collections or walled-off necrosis and not as pseudocysts within the pancreas. Coming to pancreatic sepsis, this is a major complication which is accompanied with a high morbidity and mortality rate and occurs following secondary infection of either pancreatic necrosis or peripancreatic necrosis, or rarely a pseudocyst which gets infected. The problem is that the CT diagnosis of pancreatic sepsis is difficult, as the only sure sign is the presence of gas, which may be seen only in a small percentage of cases, approximately 1/3. In the other 2/3, the only way to make the diagnosis is to perform a CT-guided aspiration. This is an example of a patient with classical pancreatic sepsis, where you see a large fluid collection seen in the pancreatic peripancreatic region, but there are telltale signs in the form of specks of air. The presence of these specks of air tips the balance and indicates that this is pancreatic sepsis. An important point whenever we need to do an aspiration to prove the diagnosis of pancreatic sepsis is that we mustn't transgress large bowel. The reason is twofold. Firstly is that if we go through the large bowel, we may inoculate bacilli which normally lie in the large bowel into the peripancreatic fluid collection and thus convert a sterile fluid collection into an infected collection. The second is that bacilli which may be present in the large bowel may be aspirated, and therefore the microbiologist will see bacilli on the slide and then give a false positive result to say that the pancreatic collection is infected. Here we can see that there's a large collection seen in the lesser sac with evidence of air within and multiple specks of air with a large fluid collection here with specks of air within, and these are typical of pancreatic sepsis as compared to this where you see a well-defined fluid collection out here. There's no air within. Patient clinically was ill with fever and leukocytosis. So the only way for us to prove this diagnosis was to do a CT-guided aspiration. And when we did that aspiration, what we got was pancreatic sepsis in the form of pus. CT intervention. Pseudocysts rarely become infected, so we rarely need to intervene with pseudocysts. Where we need to intervene are acute necrotic collections or walled-off necrosis, because these usually require intervention. We do, of course, do CT-guided aspiration to know that these are sterile or infected, but very often, once they're infected, we need to do drainage as a temporizing procedure, which may be using a pigtail catheter or intercostal drainage tube, which simulates surgical drains. Age-old procedure of putting in a pigtail catheter into a collection, but the problem that has happened with pigtail catheters is that they tend to get blocked. Another example to show you the collection and the pigtail catheter in situ. So now what we have switched to is actually using thick bore surgical drains, which are intercostal drains. And these drains can be 24 French, 28 French, 32 French, and they're quite easy to insert as long as there is nothing intervening in your passageway. And that's why sometimes we have to use different routes, where we might have to use a paravertebral route or a lumbar route to insert the intercostal drain. But these are extremely effective. Patient with a subphrenic abscess following acute pancreatic sepsis, and we've put in an ICD into the collection. Other complications which occur in acute pancreatitis are the gastrointestinal complications and vascular complications. Gastrointestinal complications, one of the first is a bowel fistula, or you may have ischemic bowel. And these essentially occur because of autodigestion of adjacent tissues by the pancreatic enzyme. And that's also what happens with the adjacent vessels, and that's how you end up with vascular complications. How would we diagnose a bowel fistula? One is presence of air in a non-infected collection. That means that there is some communication with bowel, or more importantly, with extravasation of oral contrast. And sometimes, especially when they reach the skin surface or subcutaneous tissues, then a sinogram may be useful to inject through the skin opening to see communication with the bowel. Ischemic bowel occurs essentially because of autodigestion and involvement of the blood supply to the small bowel, as a result of which resulting in ischemia of the bowel. An example of an ischemic bowel where you can see that there is air within the wall of the bowel loop as a result of pneumatosis intestinalis. The vascular complications occur, as I mentioned earlier, due to injury to the vessel wall by pancreatic enzymes. This results in pseudoaneurysms. The commonly involved vessels are the splenic, gastroduodenal, pancreatoduodenal arcade, basically all the vessels around the pancreas. This can result in hemorrhage. Also, another complication which occurs is venous thrombosis, and that's fairly common. Here's a dramatic example of a patient who had acute and chronic pancreatitis, repeated episodes of pancreatitis due to his chronicity of his pancreatitis, where you can see that there are calcific densities within the pancreas, multiple fluid collections, and more importantly, a large fluid collection here, which is mildly hyperdense and inhomogeneous. And that's why it's very important to inject contrast, because here you can see the pseudoaneurysm is beautifully seen here with an extensive mural thrombus here. A small splenic arterial aneurysm you can see very nicely, especially on the VRT images, and that's because of involvement of the splenic artery. An example of an aneurysm which is arising from the celiac artery. In fact, this was a bridging aneurysm which arises from the celiac artery and also communicated with the common hepatic artery here. Quite nicely again demonstrated on the VRT images here. And this patient was treated by the placement of a stent, so it bypassed the whole route of the two feeding areas of this aneurysm. Hemorrhage may occur in adjacent organs, and here is an example of retroperitoneal perinephric hemorrhage occurring following acute pancreatitis. As I mentioned, venous thrombosis is a common complication which occurs in acute pancreatitis. This should be looked out for fairly carefully. An example of a splenic vein thrombosis, a curved MPR to demonstrate this, and a thrombus seen within the portal vein out here. Acute pancreatitis also has need to have prognostication done, and CT plays a role in the prognostication in acute pancreatitis. We have a CT severity index where it is classified from grade A to E based on the CT appearances. Grade A would be a normal CT. Grade B, diffuse pancreatic enlargement with or without necrosis. Grade C, necrosis and peripancreatic edema. Grade D, when there's a single peripancreatic fluid collection or peripancreatic necrosis. And grade E, 2 or more fluid collections or gas. It was felt that actually the CT severity index needed to be taken a little beyond just the grade A and E. So we now have a CT-CSI index in which we also take into consideration the extent of necrosis. So the grade A to E stays, and they are given 0 to 4 points based upon which is the grade. Grade A is 0, grade E 4. And additionally, 2, 4, or 6 points are added depending upon the extent of necrosis. If less than 30%, 2 points. Between 30 and 50%, 4 points. More than 50%, 6 points. And how does this translate? You're going to have a scale of 0 to 10, because if you have grade E with more than 50% pancreatic necrosis, it's 4 plus 6, which is 10. And if you have basically a normal appearing pancreas with no necrosis, it will be grade 0. So this translates in that if you have a 0 or 1 points on the CT severity index, these patients actually showed no morbidity or mortality. If they had 2 points, it had a 4% morbidity and no mortality. So basically these patients would do very well. But if you had a CT severity index of 7 to 10, these had a 17% mortality and a 92% complication rate. So these are individuals you would want to look at very, very carefully, get follow-up imaging done to see whether any complications are developing or not. In addition to the CT severity index, a modified CT severity index was brought in, which was very similar to the CT severity index. It just made a few differences, where if you notice that in the region between focal or diffuse pancreatic enlargement and peripancreatic inflammation, CT severity index made a differentiation, but the modified CT severity index makes no differentiation, and it gives both 2 points, elevating a focal or diffuse pancreatic enlargement into the peripancreatic inflammatory group. Further, they made no differentiation whether there was a single acute fluid collection or 2 or more fluid collections, and elevated them into the 2 or more fluid collection, giving them more points. This modified CT severity index further did not make any real differentiation whether it was 30% or 50%, and gave them same score as compared to CT severity index, which upgraded the points. Where modified CT severity index gave more points was if there was an extra pancreatic complication in the form of GI tract involvement, vascular involvement. For that, they gave more points. But frankly, they really don't make a difference, because if you look at the CT severity index and the modified CT severity index score, you'll see that the points are relatively similar. Mild to acute pancreatitis would be 1 to 3 on a CT severity index, 2 on the modified CT severity score. Moderate would be 4 to 6 on both, so there's agreement there. And severe would be 7 to 10, which is 8 to 10 on modified CT severity index. So basically they're very similar. So whichever CT severity index score you want to use, whether it's CT-CSI or the modified CT-CSI, it's fine. CT severity index is actually an excellent prognostic indicator for local pancreatic and peripancreatic complications. The clinicians use Ranson's and Apache. These are clinical scoring systems. These are superior in prognostication of systemic complications, especially in the first week when there's a systemic inflammatory response syndrome and the local changes that we have in pancreatitis are not so visible and demonstrable at that stage. So those scores are very useful at that time, and of course subsequently looking at systemic complication. So a combination of both the clinical and the CT scoring systems is very, very useful and good because it provides a more comprehensive prognostication in acute pancreatitis. Just to review a few cases of acute pancreatitis, just demonstrating to you the spectrum of what happens in acute pancreatitis. Here you can see that the pancreatic gland is enlarged. You can see that there is a slight fuzziness of the fat around the uncinate process of pancreas, resulting in a minimal amount of peripancreatic inflammation. And that's quite nicely seen on these coronal images, where you can see that the pancreatic gland is enlarged out here, and there's a slight alteration of the peripancreatic. So basically, a mild interstitial edematous pancreatitis. Here's another example where things are a little more progressed. Of course, you have the enlarged pancreas here. You have a small amount of peripancreatic fluid collection seen anterior to the pancreas out here. Small peripancreatic fluid collection anterior, but no necrosis within the pancreas and an homogeneously enlarged pancreas. In this case, there's a slight more progression in the process where you can see that the pancreatic gland, though enlarged, is homogeneous. There are evidently areas of necrosis along the surface because the surface of the pancreatic gland is irregular, but within the bulk of the pancreatic gland, no necrosis. There's peripancreatic fluid collections, but these fluid collections are not just liquid. There are solid components and debris within them, and these are fat densities and debris within these collections, and this is why this would be considered as an acute necrotic collection and not a acute pancreatic fluid collection. Another example to show you where you can see the entire pancreas is necrosed and replaced by a large fluid collection, which previously we would have termed as a pseudocyst because it's well defined, looks purely to be liquid, but actually within there are multiple areas of fat density within and areas of debris, there's solid small enhancing areas within, and this is an acute necrotic collection. But it's most likely 4 weeks or beyond because it has a very nice, well-defined margin and would be an acute necrotic walled-off necrosis. Example of extensive pancreatic necrosis where you see areas of hypodensity within the pancreatic gland, extensive areas of necrosis within as a result demonstrating hypodensity, and of course the peripancreatic necrosis, again hypodense tissue adjacent. And an obvious pancreatic sepsis where you can see a large fluid collection in the pancreatic region and peripancreatic region with a telltale sign of areas of sepsis in the form of specks of air within the collection. So in conclusion, what is the role of imaging in acute pancreatitis? In the diagnosis, yes, limited, only if the classical clinical signs are not there of severe epigastric pain radiating to the back or the amylase lipase levels being not elevated more than 3 times normal, then we would need to have a CT done to see whether there is swelling of the pancreas or not. Very important is CT to differentiate between edematous and necrotizing pancreatitis, where CT demonstrates hypodensities within the pancreas on the adjacent peripancreatic tissues, indicating that this is necrotizing pancreatitis because this has a much higher morbidity and mortality. CT is very important to differentiate between peripancreatic fluid collections because they have different managements. Detect pancreatic sepsis, which is the main complication. Look for the telltale signs of air, and where there is no air within the collection, do a CT-guided aspiration, obtain material for microbiology. And then act as a guide to drain infected collections. And as I've mentioned, pigtail catheters tend to get blocked because there may be some debris which may not be recognized on the CT. And that's why today, if you have a window available use thicker bore catheters, which are the ICD catheters, and you can go up anywhere from 16 French to 32 French and put in depending upon what is the consistency of the fluid that you see. CT also has an important role to look for any other complications which I mentioned, which essentially one would look at the gastrointestinal and the vascular complications. And of course then for prognostication, and as I mentioned, you can use the CT severity index or the modified CT severity index. Both are excellent and tell nearly the same story. In addition, of course, clinical scoring systems of Apache and Ranson's are useful to combine with the CT severity index. And finally, in conclusion, important to get the terminology right in peripancreatic inflammation and taking from the Atlanta classification. Fluid collections which are seen in the first 4 weeks with no necrosis or infection are termed as acute pancreatic fluid collections. After 4 weeks, an encapsulated fluid collection without necrosis or infection is termed a pseudocyst. Fluid collections in the first 4 weeks with necrosis are termed as acute necrotic collections. And encapsulated fluid collections with necrosis after 4 weeks are termed as walled-off necrosis. And remember, any intraparenchymal fluid collection due to pancreatitis are referred to as acute necrotic collections or walled-off necrosis and not as pseudocysts. Thank you very much.